Good afternoon. In the following minutes, I will present some data on the role of international travels in the incidence of measles cases in the Americas and mainly in the Latin American countries. Measles elimination is defined as the interruption of endemic transmission by 12 months or more in the presence of a high-quality surveillance system. However, some cases can occur by importation from endemic areas or by a local transmission associated to importation. Currently, all regions of the World Health Organization have goals of elimination, but until now, only the region of the Americas has achieved such goal. The policy of measles elimination is based on the standardized case definitions and on the compliance of quality indicators of epidemiological surveillance and immunization coverage. Suspected case is a person with a fever and maculopapular rash accompanied by one or more of the following signs: cough, rhinitis, or conjunctivitis. Confirmed case is an individual who fulfills the definition of suspected case and is confirmed by laboratory or by an epidemiological link to other confirmed case by laboratory methods. By the other hand, imported case is that who acquired measles outside the country and the American continent during the incubation period prior to onset of rash. A case associated to importation is that who is part of a local transmission chain originated by an imported case. In contrary, endemic case is an individual that is part of a local transmission chain which remains active during 12 months or more. Before the introduction of the expanded program of immunization, more than 220,000 cases and approximately 12,000 deaths occur annually in the Americas. After the elimination initiative of the Pan American Health Organization, endemic transmission was interrupted in 2002 in Venezuela. However, in 2013, Brazil presented a reactivation of the endemic transmission, whose last case occurred in 2015. Finally, in September 2016, the Pan American Health Organization International Committee of Experts declared that the Americas region is free of measles. As observed in this slide, since 1998, the immunization coverage with one dose of measles containing vaccines is greater than 90% in the Americas. In 2015, most countries of the region presented a coverage equal or greater than 90%. However, coverage with 2 doses remains low. This is an important cause of some transmission in children and in adults who only has 1 dose and not 2. And then it's important to improve the immunization coverage with 2 doses. A key indicator of surveillance is the rate of suspected cases, which expected value is at least 2 cases per 100,000 inhabitants. The slide shows the fulfillment of this value in the last 11 years, with an important increase in 2007 and then a decrease in the following years. It's important to note that the increase in 2007 should be investigated because this increase is not related, apparently, with other exanthematic diseases in this year. Then it could be an improvement of the notification of cases, but is unusual, this increase. In my opinion, in all the countries should analyze this increase and investigate the cause of this. This is particularly important because since 2014, chikungunya and then Zika cases were introduced in our continent, and probably the expected value for these years and the following will be greater than the expected value of 2 cases per 100,000 per inhabitants. Okay. Most of the importations came from the WHO regions, where measles remains endemic. In the period 2010 to 2015, occurred 61 outbreaks. In 60 of them, only 4 had more than 20 cases and affected Canada, the United States, Brazil, and Ecuador. Other nations as Argentina, Chile, Venezuela, and Mexico have had unique cases or small outbreaks. Genotype D4 has been the most frequently identified in the outbreaks. However, genotypes D8 and B3 were more commonly found in Greek outbreaks. In this map, we can see that Canada, the United States, Brazil, and Ecuador had been the countries with more imported cases or related to importation. It's important to note that one of the biggest outbreaks, greatest outbreaks of the continent, occurred in Brazil in 2013 and lasts until July 2015. Most of the cases of the period 2011 to 2016 has been imported or related to importation. The West Pacific region, the European countries, and the Southeast region of Asia had been the most frequent source of importations. Most cases have occurred in individuals from 1 to 39 years of age who are inside in the target group for routine vaccination or for supplemental immunization activities in the elimination strategies. However, Approximately 25% of cases corresponded to age groups not preventable by the immunization program. In 2013, an importation not identified of genotype D8 provoked one of the most greatest outbreaks in Brazil, after this country had achieved the elimination for more than 10 years. 4,094 suspected cases were reported to the Ministry of Health of Ceará, a state of Brazil. Of these, 916 were confirmed by laboratory methods or by epidemiological link to another confirmed case by laboratory. Due to the outbreak last until July 6 of 2015, and according with the case definitions, the continuing transmission of measles was considered as endemic again. The state of Ceará presented more than 95% of immunization coverage since 1992. However, this high coverage was not homogeneous, and some neighborhoods of the city of Fortaleza and other municipalities had accumulated many susceptible individuals. Under conditions of previous measles elimination and high coverage of routine immunization, children less 1 year of age and individuals of 15 to 19 and 20 to 19 years of age had the greatest risk of infection. The last case of measles acquired in an endemic transmission chain in Mexico occurred in June 1995. However, since some imported cases has occurred in the country since the elimination. All of these cases are imported or related to importation. The last case of measles acquired in an endemic transmission chain in Mexico occurred in June 1995. As said previously, but since 2000 to 2013, 183 cases occurred in the post-elimination period. Of these 183 cases, 182 occurred in 7 outbreaks, and 1 was a unique imported case. The cases were associated to 1 to 8 transmission chains. Were identified the genotypes H1, B3, D4, D6, D8, and D9. European countries, those of West Pacific region, the United States, and Venezuela have been source of the imported cases. In 4 of these outbreaks, history of international travel well clearly identified. The outbreak of 2013 occurred in Playa del Carmen, a tourist place close to Cancún, Quintana Roo. The primary case was a boy from England that did not travel to Mexico. The index cases were two sisters of this boy who were infected in the United Kingdom and who traveled to Mexico in the incubation period. Both girls provoked 5 secondary cases in 3 chains of transmission. The indicator of suspected cases per 100,000 inhabitants was greater than expected value in Quintana Roo and in the country. As you can see in these graphs, all the time, measles suspected cases were reported to the surveillance system in the country and in the state of Quintana Roo, where is located Playa del Carmen. The first transmission chain related to importation was in Playa del Carmen with 2 secondary cases. The second chain occurred in the same place and provoked 4 secondary cases, and finally, the third chain occurred in Canada through a man infected in Mexico and who infected his son in Canada. In summary, importations of measles have occurred under conditions of high but not homogeneous coverage. Most of cases were unvaccinated individuals. Great proportion of cases were related to international travels. International travelers not immunized are at risk of measles infection, even in countries that have eliminated the endemic transmission, as was seen in the Mexico outbreak in Playa del Carmen. There are more probability of dissemination of imported viruses in places with low vaccination coverage or with high coverage but not homogeneous. Belonging to programmatically non-preventable groups and no vaccination in the target group of the immunization program were factors associated to transmission. And this is an important finding of the behavior of imported cases in Latin American countries, because the risk is not only for travelers, but is for those countries who has eliminated measles in endemic way. Then it's important to assure that people who travel to endemic regions and people to travel from endemic regions to regions in condition of free of measles, take precautions and take the doses of measles vaccine that is necessary to prevent transmission. Many thanks.